Yes.
Um, so I sort of figured I'd go through a couple of different viruses, actually, flu, RSV, and COVID. Um, we're coming into a winter period, finally coming out of a pandemic, however you choose to measure that. And I think this was just a really good opportunity to sort of refresh a few very simple things, mainly to do with vaccines and disease spread. And if folks want to get into other details about treatments and trials, I'm happy to go there, but I appreciate you got a tight agenda. So it's worth just reminding, let's start with flu. Usually we have a really defined flu season, and you can see here from all the graphs over sort of the last decade that it typically peaks in the Northern Hemisphere in the central US, including North Carolina, starts going up in December, peaks sort of January, February, and usually a bit of a tail maybe into March, but falls away. And whilst there's a bit of variation in the magnitude of each flu year, you can see 2017 was pretty rough. Sometimes it doesn't turn up at all. And in 2021 and 2020, during the pandemic, we basically mitigated our way out of any influenza at all. Last year sort of threw us back into more of a typical year. And so if folks look here at the red triangle line, you can see that not only was it a high peak in terms of influenza prevalence, but it actually occurred really early. And so this was also seen in the Southern Hemisphere last year, and sort of I think really a measure of the change that viruses interact with each other. We copped our flu season sort of November, December. It actually caught people off guard because we missed an opportunity to vaccinate a lot of people ahead of when flu arrived. This year, well, actually, and while I'm on that, that was also true in terms of an early season onset for RSV that you see here. These are the cases of RSV that we sort of really very unusually occurred in an early peak around October to December, earlier than we usually think. So far, the Southern Hemisphere this year has had what would be very much back to a normal year of things arriving in the months that they expected. So I'm hopeful as we've come out of the pandemic and really all of our mitigation efforts have largely faded away from a community point of view, that this may be more of a regular season, albeit with COVID still present. One of the things that we're going to talk about, that was flu. This is RSV. And so people may not really, there's not a community image of what RSV is. I think when we think about it, we think about it as the virus that causes young neonates to become critically unwell. Their lungs, when they're less than 1 or 2, just are not formed in a way that can handle this virus. But for older adults, someone who's healthy, this would be a persistent, annoying, runny nose, sore throat, and sort of very much upper respiratory illness. But you can see here, when you get up into your 70s and certainly beyond, this is a major cause of winter hospitalization for older adults. And so if you're getting, let's say that very last column, about 250 people out of every 100,000 get admitted to the hospital because of complications of RSV, a good number of those actually pass away from this each year. So it is something that, whilst we don't sort of have a mental image of RSV, it's certainly a co-circulating virus that does cause us a lot of problems. That's RSV. COVID is still here. I wish I wasn't having to still sort of mention that, but it is. For the 4th year in a row, we've had a late summer spike. And for the 4th year in a row, that has started to fade back down. Thankfully, not as severe as the amount of COVID that we would typically see in the winter. But I think my sort of way of looking at this is that it does sort of paint the picture that probably we're going to continue to see COVID here for quite some time. And I think it's likely to expect that we'd again get a winter period spike of this coming through in January, like we have for the last 3 years. There's nothing new on the horizon about variants of COVID that concerns me at all. And so I just want to put that there to say, so far we've had nothing in my mind but reassuring information in terms of the way our current vaccines are matching with what have been a series of little Omicron viruses. These have not shown to be more pathogenic at any point so far this year, which I think is reassuring. So it leads to sort of the first clinical question, which is maybe, well, how do I, if there's 3 viruses that are going to be circulating together, COVID, RSV, and flu, can I pick the difference? And I frankly no longer can. I think it used to be easy in 2020 because COVID was that much more inflammatory and sort of severe. Frankly, it was the only game in town. Whereas these days, if you look down these sort of classic columns, maybe you could say that influenza is sort of this quick onset, systemic muscle aching, joint aching, fatiguing sort of systemic illness. RSV, much more commonly the bad persistent head cold. And COVID still occasionally comes in with more systemic features and sort of that classic loss of smell and taste. We still see the odd person, but really they're blended together a lot. I can't really sit in front of someone in a clinic situation and know which of these three that they're going to have. We do occasionally still see long COVID, which I think is the other thing that I use when I discuss with people who may be a bit on the fence about COVID. I would apply this to myself. This is something I don't want to get. You know, I'm a relatively healthy young adult, so I don't think my fear of COVID severity is that great, but I sure don't want to be knocked off my feet for a bunch of months, secondary to a virus that I can certainly help prevent. We can go into that in more detail if folks want. So a few little tricks for the sort of the outpatient world. We're getting better at being able to now tell outpatients which of these viruses they might have. So there's now, you know, we've all had rapid tests for COVID. There are now approved rapid tests that differentiate COVID and flu, although they've been pretty hard to find and haven't really made their way into the sort of North Carolina market to any extent. But just suffice to say that you may start hearing people, particularly maybe over the next 12 months, start talking about the fact that they've home tested themselves for flu. And these are actually FDA approved now and quite accurate, although, to be fair, not cheap. So let's get into vaccines. So I think one of the biggest sort of, well, there are many failings in vaccine rollout through the pandemic, but one of the real struggles was our sense in the community. Lots of people got the sense that vaccines weren't working because people were still getting sick. And I want to really try and differentiate how I now speak about vaccines. And this, whilst everyone was aware of this during COVID, because it was all we were talking about, exactly the same information is true for flu. I love to talk about this with two measures of success that a vaccine can give you. The first being simply what proportion of infections don't you get? So we think on average these days for a COVID booster, certainly the last few, cut about 50% out of the numbers of infections. So, you know, for us at a large hospital, we have, you know, at the worst of our Omicron peak, we had 1,000 people sick at one point. And yet, if we hadn't had vaccines given as boosters to those folk, you know, we're probably looking at 1,800, 2,000 cases. So about half of the cases won't occur. That's a win in itself. But the graph on the right speaks to a different point. That speaks about severity. So if you're in one of those unfortunate people who will still occasionally get an infection, how severe is it? And it goes down substantially. So we very rarely see people in the hospital who have been recently vaccinated. They'll be there because they've had a breakthrough infection, but the severity of that really falls away. And the same is true as with flu. The bad flu season, people in the intensive care almost universally will be unvaccinated for that season. So I sell these vaccines now with two messages in mind. Can they help you stop getting sick? Yes. Will there be some breakthroughs? Absolutely. And that's not surprising. But even if you do get a breakthrough illness, it will generally be shorter. You'll be less infectious to people around you, and it'll be less severe. So we have 3 COVID vaccines now available. Sorry, I mistakenly not updated my slide. That should have said last month. Pfizer, Moderna, and Novavax have all tweaked their recipe to be sort of really targeting the most contemporaneous family, if you will, of Omicron variants. These are holding up from sort of lab data actually quite well against current strains. So I think the match, if you will, is actually at the moment pretty good. And actually the CDC came out with just a really nice, simple approval message, which is anyone over the age of 6 months can get a dose, and that there's a benefit for everyone to do that. Now that benefit may be different in different age brackets. And so I want to talk about that. Actually, I'll get to that on the next slide. The benefit may be different in different age groups, but the CDC were very clear in their sort of guidance to say that recommendation for vaccines for all Americans may appear different than, frankly, other countries will lead to. I suspect other groups will say, hey, we only want to revaccinate our older adults over 65. And the CDC sort of took a line of saying, we hear you that the benefit to younger adults is probably less. They're healthy anyway, but there's some benefit. And we know that COVID has distinctly affected folks who are from African-American and Latino communities more. We know that it has negatively impacted health outcomes from folks who already struggle with health access and health literacy more than it did for lots of other viruses. And so the means of making this a broad recommendation across all age groups and all comorbidities is to try and negate that. It doesn't matter who you are. This should be something that's available to you to try and make sure we don't further stigmatize and divide on health divisions. I'm going to skip some of this just for convenience. So, the guidance is pretty simple. There's almost no one these days, I don't know if any of you are still seeing people who are unvaccinated and suddenly interested in a vaccine. I don't know who those people are. Mainly it's people who've already had plenty of vaccines before who are interested in getting another one. And I think for them, the message is really clear. One dose, take your pick, and you'll be well covered heading into next year. A little bit different for pediatrics, but I'm not a pediatrician, so I'm going to dive away from that. It's more valuable the older you are. So like in that very first RSV slide that showed that, the older you get, the more hospitalizations you get from RSV. It's probably true both that is also the case in COVID. So the older you are, the less you've remembered your old vaccine, the less that sort of memory of having been vaccinated holds up, but also likely the more comorbidities you have that make COVID more severe. So for both of those reasons, whilst I would say anyone can go and get a COVID vaccine, I have a more compelling and stronger argument and more forceful hand with my sort of 60, 70, 80-year-old adults, because I think in general, they're under more pressure to be vaccinated. Let me put it that way. So to pivot slightly to flu, there's no difference in flu this year than previous. We think from Australian data, the match is actually going to be really good, so better than most seasons in terms of blending the strains with what's circulating. And really the only decision is the person in front of you over 65 or under? And there's now actually really clear data that says if you're over 65, you should get a higher dosed flu shot. The argument being, again, older adults respond less efficiently and for less durability to a vaccine, so we should give them a bigger response to make sure that offers them the same level of protection. And there's a few different brands that you can see here that are designed, in fact, to give you a better dose, if you will. If I see someone who's 70 and they went and just got a regular flu shot, that's great. I don't need to go and sort of reboost them in any way, but in general, there's this sort of preferential delineation here for older adults. Part of that comes out of a bunch of old data looking over the last 12 months that says, what's the VE, the vaccine efficacy for old and younger adults? How well does the vaccine work? And so as you can see through the second column on that table, typically for a vaccine, we would expect somewhere around high 30s, 40% of all infections would be averted. So, more than a third of cases of flu would be stopped. But if you look at the older adults in the final column with red, some years our older adults don't really make a great response to flu at all. It's notably poorer in terms of its prevention. So the argument then that counterpoints that is, well, hang on, if we can crank the dose up, does that help? And in fact, there's a bunch of good studies now that show that, in fact, that really does make a difference, both in terms of the sort of blood test, how did I respond? But at the end of the day, how many people actually go and get sick? So we offer older adults now a higher dose, and I think there's some pretty robust reasons to think that's the right step. So where that comes out of, if people really want to get into the weeds, is a series of different studies looking at hospitalized patients, looking at older adults, coming into the emergency room, looking at people who actually pass away from influenza. And the key point is that final column is that no matter which way you look at it, for older adults, the bigger the flu dose, the better their response is going to be. And so this is now an official sort of CDC recommendation. Let's talk briefly about RSV, and then I'll probably have burnt through my time. So there were two big trial sets that came out, one from GSK, one from Pfizer, looking at two different structures of RSV vaccines, both of which worked really well. So they, in terms of percentages of reducing lower respiratory complications due to RSV, so like viral pneumonia, the kinds of things that lead older adults into hospital, they cut out about 5 out of 6 cases. So that is pretty good, robust vaccine effectiveness. They were only trialed in people over the age of 60. So we don't really know how these work or how they should be given in people who are younger than 60. They were not trialed in immunosuppressed people, only healthy older adults. But again, good reason to think that they'll probably work in immune suppressed patients too. The CDC have a sort of a slightly nuanced recommendation when it comes to RSV vaccines. They say it should be done through shared decision-making for anyone over 60. So what does that mean? That means on the surface of it, we have a conversation and say, hey, is this something that we want to give to you? And I think where it comes from is it comes from two things. It comes from, number one, anyone who's at risk of bad RSV is also at risk for severe COVID and flu. They've probably got lung disease, they've probably got heart disease, diabetes, maybe they're older, maybe they're immunosuppressed. And so if I'm recommending RSV vaccine, I'm probably recommending the other two, and there's more data and strength on the other two at this point, and COVID's here right now. So to me, RSV vaccine is the third in the trifecta in terms of importance, not to say that I'm not recommending it. The other point that sort of gives people just a little bit of pause is that there were a few side effects seen pretty rarely. You can see there 3 out of 20,000 cases of some neurologic issues with this vaccine. Not nearly enough for me not to have a really strong conversation with a patient who's at risk to say, hey, this vaccine is something that will give you great benefit. But if I'm seeing a 60-year-old who's robust and fit and running triathlons, this doesn't need to be for that person. But someone who's at risk, both really good and effective vaccines, especially once people get over 70 or 75. So like I said, I sort of rank these in a tiered level of importance. COVID's here now. So I think if someone says, I only want one vaccine, take your pick, I would say COVID. We have good data to support giving COVID and flu together. If you're only going to capture someone once, you can hit them up at the same time, and that's actually quite safe. We don't know as much about the RSV vaccines yet. So whilst that can be done, I pause and bring them back for their RSV vaccine a little later. I don't know how much it affects this group, but vaccines over 65 for Medicare patients often need to be given by private pharmacies, not through individual clinics like us here at Duke. So at best, I can see my 70-year-old and say, hey, you need to go to a local Walgreens to get your RSV vaccine. Treatments, RSV doesn't have any. That's the reason to try and prevent it. We do have treatments for young babies. There's now antibodies. And we are now learning that for pregnant mums, actually vaccinating the mum in their 3rd trimester is really helpful. If it's the right time of the year that the baby's about to be born as RSV season arrives in the winter, if you vaccinate mum a month or 2 in advance of that, her antibodies protect the baby. So this is the first year that this will really start to kick in as a recommendation for women who are pregnant now in their 3rd trimester. I'm going to skip through this just a tiny bit. We can probably skip through some of the treatment discussions. I want to leave time for discussion, but suffice to say that we now have a liberal availability of COVID treatments for someone who gets sick, who you're worried might be an older adult or someone who's at high risk. We have the same widely available influenza treatment for someone who's at high risk, and this can include, remember for flu, we have an availability of medicines for someone who's been exposed. So let's say your great-grandmother is 95 and she's in the house with someone who's got flu. There is benefit in preventatively treating the at-risk person who's not yet sick for influenza. I figured I'd just end on a sort of a talking point, which is like, where's all this going? Here we are talking about 3 vaccines for people in the winter: COVID, flu, and RSV, whereas traditionally 5 years ago, we only had flu shot. It's a lot harder to convince people that this is the right step. It's a lot harder to logistically line up their arms for 3 times as many doses. So we have come quite some distance into developing vaccines that are blended with all of these 3 into the one shot. So they're not available on the market yet. They're sort of in late phase development. But the idea makes so much sense to me that at some point in the next 1 to 2 years, I would predict, I can give you a single vaccine as we come into winter that can then say, right, now you've covered for flu, whatever the COVID strain is that's circulating, and here's some RSV coverage as well. And that's it. And it's done in one shot. And that would be so remarkably easier for all of us, I think, rather than the current sort of mixture of all things. So with that, I'm going to probably conclude, the sort of the, how do I stop my sharing? There it is. I think the message is, I expect we're going to go back to a regular flu season and RSV season when all of these viruses arrive in January and February. We've got plenty of COVID still here now, so the current COVID boost as a single dose for anyone makes a whole lot of sense. You can give it at the same dose to a flu shot, high dose if they're over 65, regular dose for anyone else. And if you're over 60, and particularly over 60 with risk factors for heart and lung disease, then an RSV vaccine makes a whole lot of sense for that person. And we'll see where the season goes. I've been proven badly wrong for the last 3 years with COVID. So I hope my prediction of a more regular year comes to pass. So thank you.
Thank you. That was fantastic. Thank you so much, Dr. Wolfe. There was some questions there. I'm going to ask Dania to unmute herself and ask her question, please.
Hi, yeah, I'm Danya. I use she, her pronouns. I'm a social worker at Duke Family Medicine. I was just wondering if you could maybe provide some insight about the Duke decision to not continue requiring COVID vaccines, considering everything that you just said. It is very confusing to me that the flu vaccine is still required, but the COVID vaccine is not.
Yeah, and that's a great question. I'll separate requirement that ties to your job from the desire for you to get vaccinated. Let's start there. So would I want 100% of the people who walk through my hospital as an employee to be vaccinated? Hell yeah, because that'll keep them at work. Taking a week off when you've even got mild COVID, there's no disservice, there's no service there to you or our institution. And B, I don't want anyone else to get sick as a result of you being sick here. But I think where we ran into some quagmires, frankly, that we don't have with flu, I can predict very accurately when a flu vaccine is available. We know exactly how it's going to work after 15 years. We know basically what its effectiveness is going to be, and we know that roughly flu is going to continue to turn up each season. When we had to make some decisions on requiring vaccines, we didn't know if there was going to be a booster. We didn't know what was going to be in it. We didn't know how it was going to be available. And as it's turned out, it's been considerably slower for Duke to get access to that vaccine than it was to, say, get it from Walgreens or CVS, who frankly outbid us to get supply. And we didn't know efficacy. So I think it's hard to me to recommend it's hard for me to require something that ties to your employment if I can't guarantee supply chain availability or have visibility, frankly, of where COVID's going in that same way that I do for flu. Now, all that said, would I recommend to anyone who asks me or push that they go and get a dose? Heck yeah. This has been millions of doses proved super safe and very effective. And do we get sort of nosocomial COVID where, I get sick and inadvertently pass to someone else? We have, and it's awful when that occurs, frankly. But that's the difference on it's almost a legality and logistics question, not a medical one. Does that answer your question? Yeah.
Thank you. Other questions? I didn't see any other questions on the chat, but if you have a question, please feel free to raise your hand. And I did see on the chat that there was some conversation around trouble with the interpreters. I just went to the Spanish language line and I'm hearing it very clearly. So hopefully, my understanding was that that was a Zoom issue and hopefully it's been resolved.
Sorry, my Spanish or Spanglish is still dreadful, so I'm down with English.
Well, we have great interpreters for that, so no
Yeah.
no need to worry. We appreciate you being here and as always, very helpful. Okay, so if we don't have any questions, then we'll move on to our second booster update, and we'll hand it over to Catherine.
Thank you. My name is Catherine Guerrero, and I am the vaccine equity lead for the Division of Public Health, the immunization branch of the Division of Public Health. And I just want to talk to you a little bit about sort of what we're doing, where things are this fall for us and COVID vaccine. Does that look right? Can you all see my screen is doing what it's supposed to be doing?
Yeah, it looks great. Thank you.
Excellent. All right. So some of this we'll go through a little bit quickly because it may be redundant, but I will talk to you from the point of view of kind of the health department, what's changing for us, because we are now that the vaccine is a commercial vaccine, right? It does not all flow through us. It is not. Prior to this year, we were receiving and distributing all the COVID vaccine in the state. That's not true anymore. And so it has some implications for uninsured and underinsured folks and how they get access to vaccine and what that means. So, because the government is no longer purchasing COVID vaccines for distribution through the COVID-19 program. So for the last 2 years, everyone in the state has gotten vaccine through the COVID-19 program. That program is over. It's been sunsetted. So providers that are getting vaccine for people who have private insurance are buying that vaccine directly from the ways that they buy other commercial vaccines. But we do have what's called the Bridge Access Program. The Bridge Access Program and the Vaccines for Children program are the ways that we can move vaccine through the state and offer it for free to uninsured and underinsured people, both children and adults. We talked a little bit about this. Dr. Wolfe just went through this, right? But we have 3 vaccines. 2 of them are mRNA vaccines, and then we have the Novavax vaccine, which is a different technology for those who either don't want or can't tolerate an mRNA vaccine. There are multiple pathways to access COVID vaccine now in the state. So the Vaccine for Children program, which makes available free vaccine to uninsured and underinsured children on Medicaid, and American Indian Native American children. There's now the Bridge Access Program for folks who are 19 and older that are uninsured or underinsured. And underinsured for the purposes of the Bridge Access Program, if somebody is covered by insurance, if they're insured, but their insurance doesn't cover vaccine, they are eligible for Bridge Access. They're considered underinsured for the purposes of COVID vaccine. We're hopeful that, so the Bridge Access Program, we'll talk a little bit about this, will run through the end of next year, but we're hopeful that what we'll see then is a Vaccine for Adults program. So the potential for a program that will bring all vaccine, recommended and required vaccine to uninsured and underinsured adults. But CDC has given us a bridge there, right, for the next 18 months with access to the COVID vaccine. And then privately insured adults and children would get their vaccine either through a pharmacy or through their providers. So we have, I'll show you, again, running through the end of next year, all of the available COVID vaccines are available through the Bridge program, right? So you can get a Pfizer shot, a Moderna shot, or a Novavax shot at no cost. Right now we have limited doses in the state, right? So Bridge doses are accessible through local health departments across the state. They're accessible through some private providers, and then FQHCs. They are also some doses available through the federal pharmacies, so your Walgreens, your CVS. Those doses are limited currently. We expect availability to increase throughout the season. I think, as Dr. Wolfe referenced, the vaccine has been slow to roll out, right? Because it's no longer sort of one single purchase by the government. Those rollout challenges seem to be in distribution more than production. So we expect to see more availability of vaccine in general, and then more availability of bridge doses as we go through this season. Folks can use vaccines.gov, which is the CDC vaccine finder, to figure out where there are bridge doses near them. But like I say, we've been working really hard to enroll providers. Local health departments, all local health departments are required, as well as community health clinics, rural clinics, are enrolled in the bridge program and can get doses. Also, substance abuse treatment centers have access to bridge free COVID vaccine. When we were in one of the things that has changed since we were in under the public health emergency is the kind of data that we have access to in terms of thinking through equity, thinking through who has experienced highest burden of COVID. And what does that mean for vaccine allocation and how we move vaccine around the state? We are able to look at uninsured, sort of density of uninsured populations and social vulnerability across the state, and still use those numbers to allocate COVID vaccine, right? To make sure that places where we see higher density of people who don't have access to private insurance, that we can get vaccine there. Obviously, that's limited a little bit by how much vaccine is in the state, but we have at least one provider offering bridge doses in each county. So this is a map of the different types of providers that we've enrolled in the Bridge Access Program, and where vaccine is available across the state. We're working with community-based partners to address transportation issues and other kinds of kind of confidence and access issues to help people get to vaccine. You can see places where there may be long travel times, because the only provider is a health department, and you might live 45 minutes from the health department. So we continue to work with providers to make those resources available, and we can share more information about that if it's helpful. But this is just a sense of where we are in terms of provider enrollment for those free COVID doses. And then there's just a summary in terms of kind of the main points for the program. Quick note on RSV. So Dr. Wolfe covered most of this, but I do want to say that we are working with birthing hospitals and providers across the state to get RSV vaccine and antibodies. There is an RSV antibodies that are monoclonal antibodies that are administered to infants, that we sort of group them in with vaccines because they're longer lasting. For doses for the VFC program, we don't have a lot of that in the state right now, right? So there's, again, some supply challenges for RSV across the state that we're working with. We hope that will change as we get more, where RSV season is here. But this sort of RSV recommendation, in that we're in the process of implementing that with birthing hospitals and other providers, working both with adults. RSV is also part of the Vaccine for Children program, which means that parents or pregnant people under the age of 18 can get access to RSV. And then flu. So the one note I'll make here is that there is free flu doses are available through local health departments. So again, if folks don't have insurance or are underinsured in the sense that their insurance doesn't cover vaccines, there are still some low cost and free flu options available. And those can be found again through CDC's vaccine finder. So again, Dr. Wolfe did a better job of talking about this in terms of what the recommendations are from providers themselves. CDC guidance says that you can administer all three of these at the same time. But I think there are reasons maybe to think about COVID and flu differently than all three at the same time. And then I just, when I send these slides over, we've just got some slides here. We have a fall flu vaccine campaign going on. So these resources are available for you all and for communities to access. We talk a lot with communities, particularly communities at high risk for COVID, about extended date tests, right? So that we want to be really conscious about trust issues with communities, and when we have tests that maybe have expired dates on them or dates that have passed but have been extended. So we want to talk with community advocates and providers about sort of checking the date extensions on COVID tests so that people aren't throwing them out, or that have confidence that they can use them. And aren't necessarily having to buy new tests if they have tests that that they can use or that are still viable and have an extended date at home. So I'll stop sharing there, and happy to answer any questions or go back to any slides.